I think we already covered the majority of the topics, and I will just give a small tip before I start on TPN. And TPN is always held as kind of a culprit towards cholestasis. When you look at TPN, if you need to use it, don't be scared of cholestasis. Cholestasis to happen is going to be a long term. So assuming in a patient قاعد زي حضرتك ما قلتي about 37 days, if you manipulate the technique, if you know what you're giving inside the TPN, you will definitely be on the safe side. لأن في ناس فعلا الجراحين والoncologists immediately they panic. لا أنا مش عايز أدخل TPN البيشنت هيحصل له cholestasis. This is one important tip to notice. Trophic feeding, no matter what the case is, short bowel syndrome, 10 centimeters, whatever, please start trophic feeding. Trophic feeding عندك من 100 milli up to 500 milli throughout a 24 hours. So you can simply give very, very small tips throughout the day just to keep the gut. عشان when we are ready to switch, we are ready to switch. Now you can switch the slide. So I have no conflict of interest with any of my participating parties. Go ahead, please. The agenda, I'm going to start my talk about malnutrition covered, but I'm going to try to talk about malnutrition, prevalence, and the prevalence and among chronic liver disease. عارفين كلنا ان chronic liver disease compensated or non-compensated do carry a degree of malnutrition. It's between 50% up to 20%. 20% in the uncompensated and in the compensated, and about 50% or even more. I would actually say most of the hepatic patients we see, whether chronic or even when they are acute on top of a chronic disease, they're usually in a state of malnutrition. And I'm حاسة إني واقفة in your face. Are you okay watching? Okay. So the prevalence, it's very, very high. It's about 50% among critically ill patients, and our patients in liver or in the ICU are considered already critically ill hospitalized patients. Definition of malnutrition, we don't need it, but أنا عايزة أشير لone item صغيرة. Please, if you don't know if your patient is malnourished, which is going to be absurd, and we are all clinicians or at least paraclinical personnel, apply something like the mid-upper arm muscle circumference. If it's below the limits in a male and a female, then you are really concerned about the lean body mass. And if you're concerned about a lean body mass, then you are actually looking into malnutrition. Another thing that if you look into it by practice, and it is considered one of the malnutrition criteria, the serum creat. Serum creat below 0.8 is a very strong indicator that the lean body mass is very low. Plus كل الحاجات التانية, is serum albumin in addition to the general condition, a patient is not eating, starving, etc., etc. And this is going to bring me to some definitions. The second definitions as starvation. Starvation, someone who's coming with starvation is not eating or she's not eating for some time so that they're not receiving the voluminous needs of food. This is one thing to keep in mind. Sarcopenia, معناها a negative nitrogen balance. معناها a lean body mass is very, very low, but it doesn't necessarily have to be with an underlying disease, which brings the difference with cachexia. Cachexia is a complex syndrome where we do have loss of muscles basically, plus minus fat, but في underlying chronic disorder, basically cancer, pulmonary cachexia, cardiac cachexia, hepatic cachexia. So we have all chronic diseases when we reach that level where the lean body mass is dropping, plus minus fat, that's where you look into cachexia. Keep in mind that the metabolic status that you want to bring the patient into in order to sustain the best you can as regards organ function, muscle function and strength and mass, as well as the immune system, this is what we call metabolic competency. But I'm trying to move all those definitions towards what we call metabolic competency when I am planning a nutrition support plan. But we started by talking about our patients and malnutrition, and we're going to switch in the end of the lecture to the hepatic patient. In between, I'm going to just touch base on nutrition support, which was already covered, I think, in extreme details. So next, please. قبل ما أنقل على nutrition support ونقول definition of nutrition support, عايزة أعلق على proteins and the significance of proteins in our patients. If I have a patient with severe hypoproteinemia or even moderate hypoproteinemia, do you think the outcomes are going to be the same? This patient is prone to develop severe complications organs and multi-organ failures. The patient could actually develop severe infections. Time of staying at hospital increases, doubles and triples. The time to be on a ventilator increases, doubles or triples. Not only that, patients with the liver disease can even be more prone to what we call GIT bleeding. كلكم عارفينها طبعا, so shouldn't have used it. Post-operative complications in all aspects. Keep in mind, when you receive a patient, whatever the underlying clinical disorder is, wherever he's going, wherever she's going, try to supply your patient with a good amount of nutrition support in order to get the best metabolic competency, in order to get the best outcomes. Your key word is proteins. Like how to, next please, how to find out or to assess proteins in your patients. If you want to manage the nitrogen balance in a patient, and let's be practical, يعني النظري حلو قوي. Dr. Gulson gave us الحقيقة يعني literature كامل عن informations about our patients assessment and screening. بس خلينا in reality, how could I assess the lean body mass in a patient? What do you think? أنا عندي 300 عيان في المستشفى and I want to cover all my patients. حتى في العيادة الخارجية العيان اللي جاي you're under a lot of stress. What could I do? Simply simple techniques that you have within your hand. If you want to make the total proteins, if you want to assess laboratory serum albumin, go ahead. طيب جالي السيرم albumin أقل من 3.5. What do you think, Dr. Mona? Is this a hypoalbuminemic status? It is in a way, but is it reflecting the status of my patient? That's where I always say you are physicians. عشان كده nutrition should be in the hands of physicians. هو اللي يعمل assessment صح. Look at your patient globally and clinically. How does my patient look like? هو بس كده الالبومين قليل؟ لا ده كمان عنده chronic liver disease. لا ده كمان cancer patient. لا ده patient going أو حصل له operation وطلع post operative with a short bowel syndrome. So this is a very strong clue now when I correlate the serum albumin alone with the general clinical condition. I can easily say my patient is malnourished and there is a lean body mass negative side of it. So take your patient globally. I'm always trying to be as practical as possible. لأن when it comes to hands-on patients بنقف بجد نتفرج كده ايه ده هنعمل ايه؟ طب انا هطبق الايكويشنز، طب انا هطبق اللي مذاكراه. Take your time بقى. عندك 300 عيان عايزه تشوفيه ولا عندك 10 عيانين حتى في العياده. You can't do all that. We try to be practical in order to be able to cover most of our patients. Nevertheless, the levels of the serum proteins, albumin, pre-albumin, transferrin, are okay if you know what you're doing, if you're correlating it with the clinical status of the patient. But again, if they improve, does that indicate improvement of the nutrition status? Of course not. Again, look at the patient in general. How are they doing? What's the weight? What's the middle upper arm circumference going to? What is the general condition of your patient? Just to highlight on this point, لأن كتير قوي patients, physicians, they just let go. يا إما العكس يروح واقف عندها ومعقد الدنيا قوي. Many equations, many. We need time and we need practicality when we apply our science. Next, please. Now to the definition. You're fast. Thank you. What is nutrition support? Again, nutrition support means I have a patient unable to take voluminous intake of food that is sufficient. So I'm going to provide my patient with the macronutrients, micronutrients, and fluids, either through enteral nutrition, parenteral nutrition, or a combination. And we call the combination metabolic support. معناها ان انا بدي الاثنين. حرام؟ لا مش حرام. ولما يكون العيان هبتدي له بترافيك فيدنج وانا معلقه parenteral nutrition, that's totally fine. Take your time. مفيش حد بيجري وراك. اصلا مفيش emergency في النيوتريشن, which is something really nice about nutrition. فلما بيجي العيان suddenly ونلاقي تليفونات دكتور في حاله دخلت كذا كذا, please. I have within 48 hours to make up my mind to respond. So there's no emergency. Take your time and start slow and be as conservative as possible. Next, please. هقسم بس الستيجز ودكتور عمرو through some light on like the acute stage. أي critical illness بصوا له from 4 aspects. The critical stage goes through first an acute stage. Number 2, some kind of a recovery stage. Number 3, is there hypoproteinemia or not? And number 4, where is the course going to? يعني الprognosis بتاعي. Can I link the nutrition status to the outcome of my patient or not? In the acute stage, there is usually what we call a negative or a catabolic status. عشان كده قلنا no matter what stressful factor, there's insulin resistance and all the physiological aspects of that stage is ongoing. So I really need to save the muscles. I need to save the muscles by giving proteins. Immediately, I am going to answer and say never. When you give proteins, what you're doing is actually nothing. You need to save the proteins here. You need to save the muscles by giving a good source of energy, basically the carbs and fat. Again, adjust and tailor according to the underlying case. يعني لو أنا عندي مثلا حالة فيها acute hepatitis, I want to make sure I'm going to give the right amount of carbohydrates, the right glycemic index, and I want to watch out if there's cholestasis. هل هدي fat بكميات معينة. When you give fat, by the way, you can always go between 0.3 grams per kg per day up to 1.2 grams per kg per day. So adjust according to the underlying disease. بس ما تحرمش العيان في الacute stage من ده. Number 2, when you come to the recovery, the patient is now recovering, that's when we need to start to push the proteins in order to increase the level of muscle build and prevent negative nitrogen balance. Hypoproteinemia, we discussed it, and the outcomes are going to depend on what plan you're putting for nutrition support. Next, please. Assessment, مش هدخل فيها, دكتورة Gilson covered it more than enough. You assess your patient. Now, when we come to the liver, I'm going to talk about it in more details. Remember, we have basic laboratory items to cover. We have tools that you can use. Basically, I really believe in simple tools that will give you a clue. If you're a clinician and you examine your patient and you see there's wasting, التمبلز داخله لجوه, the patient is pale, you have many clues that are going to tell you immediately this patient is malnourished. As regards بقى nutrition assessment والhistory, الدايتيشن بيطلع ياخد dietary recall, بيشوف بياكل قد ايه, في any symptoms بتيجي, and so on and so forth, especially GIT symptoms. Next, please. Now, how can you make your decision on which type of nutrition support to go with? هتدecide ازاي? Number 1 and number 100 is oral or enteral feeding. So the first question will be, is my patient malnourished or at least at risk of malnutrition? If the answer is yes, and most probably the answer is yes, EN is contraindicated or not. يبقى السؤال اللي بعده, الراجل ده أو الست دي عنده gut valid or not? If there's an absolute contraindication, مش أي contraindication, مش عشان عنده شوية diarrhea أو عنده شوية distension. If there's an absolute contraindication, and we're going to mention it, that's when you will switch to think about parenteral if the patient is malnourished. But if the patient is not malnourished, وعندي contraindication, wait. Don't rush to put parenteral nutrition. You don't want to end up with a complication secondary to what you did. But always consider enteral nutrition as early as possible, unless absolutely contraindicated. Next, please. The nutrition requirements covered more than enough. In a critically ill, proteins to be covered at 1.2 grams per kg per day. Full stop. No scare. Why are you afraid? You just choose the stage where you're going to introduce the right amounts. And again, if the patient starts to show manifestations of intolerance, انزل ب 0.25 to 0.5 grams per kg per day. Take it easy. انزل شوي. اطلع بعد شوي. You can always manipulate. You can always tailor. There's no emergency. Just start nutrition support. Don't forget about nutrition. لما أشوف عيان بيقعد 9 days NPO, that's a crime. لكن إن أنا ابتديت بس ماشي على مهلي, that's not a crime. When the consultant will walk around me and say, the patient is not gaining weight. I don't want him to gain weight. I want my patient to gain muscles. I want my patient to avoid intolerance. I don't want my patient complaining of intolerance. So take the right pathway in all cases. Micronutrients, most of the formulas are rich enough. And again, look into your patient. في contraindication in أدي vitamin K, في contraindication in أدي vitamin A. According to the case, you will decide the amounts and you will tailor the amounts. Finally, Immuno Nutrition. This is a new thing surfing. No matter how many times you hear about it, أنا بس عايزة أقول كلمة واحدة. مفيش إكراه. يعني you're not really, it's like a must that I have to prescribe Immune Nutrition. But does it help in some cases? Absolutely. If the patient is going to a major operation, try to use it. Use it especially with the patients with going to liver transplantation. بما إننا in a field of GIT. Yes, use the Immuno Nutrition, omega-3, glutamine, arginine, many things. Again, it's not a must, but it could give you a better outcome. It could give you a long-term beneficial outcome. Next, please. طيب الهايلايتس على parenteral nutrition كل اللي قلناه ده فهمناه. يعني parenteral nutrition will be a must if the GIT is absolutely contraindicated. يعني عندي مثلا complete intestinal obstruction, mechanical obstruction. What am I going to do? هأكله? It's impossible. مظبوط؟ طيب لو كان في massive vomiting, massive intractable vomiting, what am I doing? Am I going to feed him? Patient has severe intestinal colics. You can't feed the patient. إنما في مثلا some kind of a hemodynamic instability, and no matter what the intensivist is doing to stabilize the patient by the inotropics, they're not reaching a level of stabilization. You can't really take the risk and add any type of nutrition. Even the parenteral is kind of debatable at that position. وتاني قلنا استنى. عندك 48 hours to decide and make up your mind. There's no rush. أنا عايزة بس يعني kind of highlight this part. اللاين بتاع parenteral nutrition is a holy line. Don't touch it. ما حدش يجي يقول لي خدنا عينات من اللاين اللي فيه TPN أو بدي double medications. It happens. It happens. They add the medications in the same line. Yes, and you have to always make it very clear. This is a holy line. ما حدش يقرب لها. عندنا مثلا في الأونكولوجي بيبقى فيه times for the chemo. You have to put your kind of table, your schedule, when to give the nutrition and when to avoid other medications. This is just an important highlighting. It's not a line to withdraw or to introduce at the same time. Yes, next please. Contraindications of early EM لسه أنا قايلاها إذا كان hemodynamically unstable. لكن لو كان على inotropics stable أدي yes. So long the patient is hemodynamically stable, you can introduce enteral nutrition, even if it's simply trophic feeding. Next. Complications of nutrition support. طب أنا خايفة من إيه في الانteral nutrition وخايفة من إيه في parenteral nutrition. Parenteral nutrition, the majority of cases بتيجي نتيجة sepsis, infection of the line itself, أو hyperglycemia عشان حضراتكم did not tailor the doses right. But to be honest with you, in good institutions, we do have what we call insulin policy protocols, where you can add the insulin to the TPN in order to control, especially لو العيان diabetic or develop diabetes for some reason. عارفين إن في hospital hyperglycemia. يدخل المستشفى يجي له hyperglycemia وتفضل معلقة. One of the stressful factors. So you want to either choose not to add the insulin if you don't have a good clinical pharmacist team, or simply try to reduce the dose and try to decrease the rate, try to give some time of rest, اعملوا titration according to the case. On the other side, EN should have no complications. يعني أنا بنزعج جدا ألاقي عيان جاله aspiration. It should never happen if you're doing the right process. If it happens, look for what they do during service. Nurse يدخل يسيرف العيان ينيمه flat وشغال عادي خالص الفيدing. Take care. The patient has to be really erect, sitting in a right position. Take care. Aspiration should never happen among your patients. If it does, there's something wrong. Diarrhea is something that's very common with food. ناكل يجي لنا diarrhea ده عادي جدا. لكن امتى اخلي بالي قوي when it's in a patient on enteral nutrition if this diarrhea is not studied why it's happening, because there are many collateral factors, including the medications the patient is taking, including adding a new medication on top. هتلاقي العيان على antibiotics كتيرة جدا جدا. And one of them is causing the diarrhea. Nevertheless, people are immediately prompted to stop the enteral nutrition. Please don't stop enteral nutrition. Just reduce the rate. Example, لو أنا كنت ماشياه على 80 ملي في الساعة انزل ل 50 ملي في الساعة. لو على 50 انزل ل 30. لو على no problem. Why are you so concerned? But don't stop. Once you stop, you are actually triggering what we call gut failure. Why do we want to reach the patient into put the patient into gut failure? You don't want to do that. So don't stop enteral nutrition no matter what. Next, please. الجايدلاينز بقى في الكرونيك liver disease. كل اللي قلناه ده يشمل الكريتيكالي ill in general. And the hepatic patient is a critically ill patient. What's the difference? Some points I want you to watch out. Please avoid prolonged periods of NPO. And to be honest with you, not only among hepatic patients, among critically ill patients in general, avoid prolonged periods of NPO. Number two, there is no need to do unnecessary restrictions. يعني يجي العيان الهيباتيك الكرونيك hepatic, I'm forbidden from eating meat. I can't eat chicken. I have been like over month and month. I'm not allowed to eat any. ولا حتى السمك. حضرتك بتقولي السمك والفراخ. لا, they are told don't eat any type of meat. Don't. It's a killer. End up and the patient starts to eat and he never thinks of what he's eating. No restrictions in diet. You need to know what to say to your patient exactly. This is very, very important. نمرة 2 خلوا بالكم العيانين دول malnourished وكلمة refeeding syndrome is something that you need to keep in mind. عشان كده أنا دايما أقول please start conservatively. بالراحة. افرض أنت you missed إن الفوسفورس قليل أو إن البوتاسيوم والمغنيسيوم قليل. There's something here. There's a clue. Watch out for your patient. And finally, I prefer using the dry weight of the patient, and the dry weight of the patient is to be estimated after removing الإديمة والأسايتس. وزي ما قلنا امبارح في الترانسبلانتيشن subtract من 7 كيلو ل 15 كيلو وانت مطمن and move accordingly. يعني هنقعد نعمل equations براحتكم بقى زي ما انتوا عايزين. انما practically speaking انا دخلت على العيان في massive ascites وفي bilateral massive edema lower limb edema. If I simply take off the weight اللي هو اتوزن عليه 15 kilos 16 kilos I'm okay. And now use that weight لأن ما أقدرش أستخدم أحيانا ال ideal body weight. This will be extremely restrictive in some patients. Again, these are the national needs in chronic liver disease. بس في شوية highlights. امتى بحتاج energy زيادة؟ When you have severe ascites and malabsorption, which is the case in our patients. So you need to increase the energy intake. Am I out of time? No, honestly, I don't like to skip the time, but I'm trying my best. Number 2, encephalopathy is not related at all to the diet, the meal. Please, مش عشان شفتي حضرتك مطلعين له الدايتيشنز جبنة وزبادي ولبن. ازاي يا دكتورة؟ طب تعالى نحسبها. البيضة 6 جرام افريج بروتين، افريج انا بقول افريج، اوكي؟ حتة الجبنة السلايساية بتاعت الجبنة الشيدر ولا حاجة 2 جرام، الراجل ما خدش على بعضه 8 جرام بروتين وهو ليه واحد في وزنه الدراي. هتقول لي 50، انا موافقة يا سيدي. ما خدش 6 7 جرام، 8 10 جرام out of 50 or 70 grams. So please be logical. It has nothing to do with that. It's related to حاجة من 2. إما إن حضراتكم اديتوه بولس، يعني حد من الأرياف زي ما قلنا امبارح يا دكتور عفيفي جه اداله بطاية كلها بحالها حلوة قوي هيروح داخل في انسيفالوباثي، أو إن الميديكيشنز أساساً اوف ريكورد اللي محدش واخد باله إن يتعمل له انيما on regular basis، إنه ياخد انستاينال انسبتكس etc. and manage accordingly. encephalopathy طلعوه من الانسيفالوباثي الأول وبعدين يبقوا زعلوا من النيوتريشنست. Okay, and then if you really sense بالcommon sense وبالmedical sense إن البيشنت is not tolerating the proteins، انزل شوية 0.25 0.5 up and down until you reach the level where your patient can really tolerate. Carbohydrates 50 to 60% ما اختلفناش عليها. الفات should not exceed 30%. I always calculate fats according to the patient's tolerance. العيان ده لو قرفان مش هزود الفات. أنا باخد من 0.3 up to 1.2. كل عيان غير التاني، وبختار الميلز البالاتابل وبعمل فورتيفيكيشن، ودلوقتي في فعلا فورمولاز امينو اسيدز فري اوف فات. So you can easily find those formulas وتقدر تعمل بيها فورتيفيكيشن للميلز المختلفة بتاعتك. Next please. Micronutrients برضو عليها restrictions. انك تحرم العيان من الصوديوم all the time. No sodium, no salt, no. طب ياكل ازاي؟ طب حط نفسك مكانه. This is not fair. ونفس الحكايه برضو ان انا يعني ابتدي افكر في الفلويد ريستريكشن. طب شوف الصوديوم ليفل الاول. If it's below 120 ماشي. وده شغل الانتنسيفست. انا دايما اقول للولاد عندي في التيم please give everyone their own ball kind of. That's their playground. Let them do it. إنما don't restrict the salts. حرام. Don't allow the patient. اديله على الأقل 500. من 500 up. Sometimes I even go a little bit higher. لأن هو على الطبخة كلها نصيبه هيبقى كمية صغيرة جدا. So you shouldn't be that worried. This is one thing very important. Vitamins قلنا قبل كده إن في bleeding tendency. لو أنا بقى الفيتامين K نقص قوي والفيتامين D نقص قوي in those patients. So you need to monitor الأول باللاب and then accordingly adjust the doses according to the patient's need. مش عمال على بطال، مش هفضل أدي كالسيوم وفيتامين دي وفيتامين A etc. بس keep in mind if it goes down and you're not following up, you are injuring your patients. And again, any mineral deficiency will lead to steatorrhea. And of course عايزة أقول حاجة مهمة جدا. المينرال deficiency بتحصل كتير قوي مع الالكحوليك patients and there are a lot. There are a lot of patients alcoholism. So keep that in mind. مش عشان احنا في مصر ما فيش alcoholism. There is a lot of cases. Okay. Dosing weight أنا اتكلمت عنها وبدل ما أضيع لكم بس وقتكم it's very easy. Don't overfeed, don't underfeed your patient to avoid lipogenesis, to avoid excessive blood glucose elevations, and try to subtract depending إذا كانت minimum, moderate أو severe ascites and peripheral edema. Next, please. So my take-home message, I gave you a headache. I'm very sorry, but actually try to be practical as possible. Your hepatic patient is a critically ill patient with some highlights, no NPOs for hours. Don't restrict sodium that much. Other than that, tailor according to the case. I thank you so much.